I am Dr. Professor P.C. Manoria, Executive President, 4th World Congress on Cardio-Kidney-Metabolic-Medicine, 18th-19th April, Hotel Leela, Mumbai. With me is Professor Chandrashekar, Editor-in-Chief, JACC Imaging. All of us know imaging is indispensable, and in today's scenario, it's not possible to evaluate, treat, prognosticate, or follow up a patient of cardiovascular disease. And the commonest disease which we face in our day-to-day practice is coronary artery disease.
Correct.
So in a patient, say with an acute myocardial infarction, we want to know whether the myocardium is dead or alive. How do you move about?
Yeah, thank you, Dr. Manoria, for inviting me. It's a great honor, and we had an academic feast. You ask a very important question. So previously, we didn't have a good way of knowing which part of the myocardium is dead or which part is alive. We used to use echocardiogram to look at wall thinning. We used nuclear techniques to see whether there is mismatch of perfusion in rest and exercise, but they were not very precise techniques. And now if I have to tell you one single technique that defeats everything else and should be in everybody's practice, is the use of late gadolinium enhancement in a cardiac MRI. So it's a special technique where we use to make the normal myocardium black, and whatever cannot be made black and what remains white is dead myocardium. And as you can expect, it has a lot of significance in knowing which myocardium will recover after bypass surgery, who will have sudden cardiac death, and what is one of the single most adverse prognostic factors. So I would say cardiac MRI is the single most important technique in this area.
So do you have any numerical figure as to what extent this indicates propensity for ventricular arrhythmias and sudden death?
Right. So this is still a moving target because we don't have very large studies in a controlled manner. But couple of things are becoming very clear. One is the size of the scar is highly proportionate to the adverse events, and it also depends on the condition that you are dealing with. For example, in ischemic cardiomyopathy, anything more than 5% of the myocardium having late gadolinium enhancement identifies a high risk group, even if your ejection fraction is not very low. So that's its strength, that even in mild to moderately reduced ejection fraction, scar has a significant amount of prognostic value. Hypertrophic cardiomyopathy is another example where again it's a continuous variable. As the LG keeps increasing, the risk increases, but generally accepted cutoffs from multiple papers is about 15% of the myocardium or more identifies a very high risk group, and that is the group that we should look at and see if the MRI can be used to make a decision towards ICD or no ICD when there are equivocal situations.
In patients with heart failure, when the etiology we are not very sure, MRI is of immense value.
Correct.
So how do you interpret, suppose the scar is pericardial or epicardial, mid-myocardial or endocardial? So how do you interpret what could be the possible cause?
Correct. That is one of the big strengths of cardiac MRI. About 15-20 years ago, this was already detected that scars have multiple properties, including the location of the scar has a lot of information that the clinician can use. The commonest example, and where it makes the biggest difference, if you want to differentiate between ischemic and non-ischemic cardiomyopathy, if you have a significant size scar that follows a coronary artery territory and more importantly is in the subendocardial location, that is a very strong guarantee that the cardiomyopathy is ischemic, even if the coronary arteries have been recanalized spontaneously and you don't see significant stenosis. So subendocardial scars that follow a coronary distribution is very classic for ischemic cardiomyopathy. Subepicardial scars, especially in the inferolateral region, associated also with septal scars, is highly predictive of sarcoidosis, although there is no diagnostic pattern, but it makes the probability of sarcoidosis in the right clinical situation very likely. The other, in non-ischemic cardiomyopathy, as mid-myocardial wall fibrosis using LG is again predictive of adverse prognosis, even if the EF is not very significantly reduced. And lastly, in hypertrophic cardiomyopathy, it often locates in the thickened part of the interventricular septum and the insertion points of the RV into the septum. In the mid myocardial fibrosis, a new variant just in the last 4 or 5 years that is now being identified is this ring-like enhancement where the entire short axis of the ventricle has a stripe of gadolinium going in a circular manner. That is turning out to be a significantly important clue to arrhythmogenic cardiomyopathies, even if the EF is not significantly reduced, like lamin, filamin, those kind of cardiomyopathies. So that again is a big, big advantage.
The other issue is, what is the most appropriate test for myocardial viability, and how relevant is myocardial viability prior to revascularization?
Correct. As you know, this area is highly controversial because randomized trials didn't show a significant benefit of viability testing. There have been limitations and criticisms of these trials, but in general we are not as enthusiastic about viability testing before revascularization compared to what we were say 10-15 years ago. Having said that, it does play a significant role in understanding viability before any revascularization procedure, and the single most important test that's now coming up as a viability marker is the use of MRI late gadolinium enhancement compared to the PET scan or the dobutamine stress echoes that we were used in the past. So, but we have to understand each of these parameters tell you different things. Dobutamine echo tells you how much of the myocardium you can recruit with dobutamine, and so that tells you what part of the myocardium is alive and can be recruited in contractility. PET identifies a completely different pathophysiology. PET tells you the area where there is a mismatch between flow and metabolism, right? And so that tells you myocardium that's alive, which is picking up glucose with reduced flow, and that tells you what is alive. Whereas MRI is not telling you what is alive, MRI is telling you what is dead. So we have to be very thoughtful when we interpret these things. For the average day-to-day practice that we see patients with 3 vessel disease, and we want to talk about whether revascularization is going to improve the contractility and prognosis, the single biggest marker is the scar thickness more than 50% of the myocardium or not. If it is more than 50% of the myocardium, it is unlikely that even if you get a good result with surgery that wall is going to improve.
What is the most appropriate test for hibernating myocardium, which is often missed many times?
Yeah, again that is also a area of active research. Currently nuclear techniques are being used for that, but my personal favorite in that area is use of dobutamine stress echo. But often it is a combination of tests that we do to understand these different parts of hibernation, like how do you know it is not repeated stunning, how do you know it is not a permanent scar or just a hibernating myocardium. So you need some measure for flow, you need some measure for function, you need some measure for metabolism. So it is often a combination of things.
There is a lot of interest in this perivascular fat.
Right.
Previously we used to look fat in the plaque by NIRS, which is the most appropriate technique, but now a lot of stress on perivascular fat. So what is your viewpoint on this?
Yeah. So the advantage of perivascular fat is that it is a non-invasive test, whereas near-red infrared spectroscopy is an invasive test. So the perivascular fat, the theory behind that is we know that ectopic fat is bad in general for prognosis, correct? But the perivascular fat is taking us one step further. What it is asking is there signatures of inflammation or something happening in that fat depot just next to the coronary artery? The vasculature here is the coronary artery, and the logic being that if there is inflammatory signals in the perivascular fat, it is probably predicting that there is a culprit vessel sitting nearby, and there are inflammatory markers that are being released both ways, from the plaque as well as from the fat. And so when you have inflammation in that area, you get a change in the Hounsfield units of that fat, and so as the fat attenuation changes, you can infer that there is vascular inflammation adjacent to that signal. And so that is the strength, and now there is a lot of data, including the famous fan study from UK in the Lancet, where it's a very strong predictor of future events, suggesting that not only are we understanding pathophysiology, but we are also able to prognosticate.
So according to which is the best indicator of future events in coronary artery disease?
Oh, that's a difficult question. If you ask the intravascular people, they'll have a different answer. If you ask the non-invasive imaging people, they'll have a different answer. But the single most important parameter seems to be the fibrous cap thickness and how much of the necrotic core is sitting under the fibrous cap thickness. Unfortunately, non-invasive tests cannot detect the thickness of the fibrous cap, but they can detect necrotic core by the Hounsfield units in the plaque, right? Low attenuation plaque supposed to have future events. Fibrous cap thickness, of course, you need intravascular imaging, mainly OCT, and that tells you. But I would still caution people that even in good studies, including the Prospect study where they did 3 vessel and characterized vulnerable versus non-vulnerable plaque, you can find vulnerable plaques, but their event rates are so low that your positive predictive value of finding these markers is very low, which makes it difficult to implement in clinical practice.
The evaluation of coronary artery disease has two components, an epicardial and microvascular. Microvascular is often ignored by most of the cardiologists.
Correct.
Epicardial, of course, catheter angiography or CT angiography and FFR.
Right.
So how do you assess microvascular dysfunction?
Yeah, so that is changing though. Previously we used to say, okay, if there is no significant epicardial CT FFR or invasive FFR is okay, event rates are low, forget about it. But the patient still continues to have chest pain, they have limitations, and so we had no good answer. But now we have techniques to look at microvascular dysfunction both on the non-invasive side as well as the invasive side. The non-invasive side often is quantitating myocardial blood flow, especially with PET, and PET is probably a great technique to quantitate myocardial blood flow. It's very well validated. CMR is also getting there. Now you have quantitative CMR that can tell you myocardial flow reserve as an indicator for microvascular dysfunction. And on the invasive side, there are a bunch of techniques, but one technique that's really coming up is IMR, microvascular resistance, right, measured invasively. And that is not only it is a good predictor for symptoms, it's also a good predictor for prognosis. And in fact, there have been studies where you have CT, just invasive FFR more than 0.8, which you would think, okay, is not significant. That group you can further divide based on microvascular resistance into high microvascular resistance or low microvascular resistance, and the prognosis is different in those two groups. So you can now, even in normal invasive FFR subsets, you can further tease out prognostic subsets. So microvascular dysfunction is getting a lot of attention now.
The problem is, particularly in diabetic patients, we routinely do CMR, IMR,
Right.
FFR. Some of them have an epicardial significant disease and also a microvascular.
Correct.
They are suitable for angioplasty based on FFR. So what will you like to do, an angioplasty or improve the microvascular? If you do angioplasty, the microvascular dysfunction may increase, and paradoxically, despite a very good, he may have angina after the procedures. So how do you resolve this?
That is so true. We don't have good treatment modalities for microvascular dysfunction, right? It's mainly right now control of risk factors. If you remember about 20 years ago, there was a lot of interest in giving L-arginine and things like that to increase nitric oxide. None of them worked. Vitamin C also had a little moment in history where they thought this will make a difference. Nothing really works. Calcium channel blockers may have some role. So since we don't have good ways of handling microvascular dysfunction very well at this time, we just focus on attacking the risk factors that can cause microvascular dysfunction. Quit smoking, obesity, control your diabetes, things like that. But the epicardial coronary artery disease is easier to fix. So everybody pretty much, if they see a significant stenosis with low FFR or invasive FFR, you first fix that and see what proportion of the angina can be taken care of that way. And then whatever is remaining we address towards microvascular dysfunction. But we desperately need good therapeutics for microvascular dysfunction.
What is your viewpoint on assessment of systolic dysfunction at the present moment of time?
Right. That's also another legacy problem. Traditionally, we have said ejection fraction is the gold standard for systolic dysfunction. But what we forget is ejection fraction is just a relation between end diastolic volume and end systolic volume. It is affected by so many things. It's not a pure contractility measure. So what's coming up now is global longitudinal strain seems to be the new kid on the block, probably functioning better, and some of us have started to feel that we should be looking at global longitudinal strain as a measure for contractility rather than ejection fraction. The trouble is ejection fraction is so established, all our cutoffs including ICDs are based on ejection fraction, and if we have to say we'll start looking at GLS, we'll have to redo some of those studies. And cardio-oncology, where GLS, all the guidelines say we should look at GLS, there's some new evidence coming, especially in the SACCHAR trial, that GLS may not be as great a marker for cardiotoxicity as we used to believe. It's certainly better than EF, but we still have more to learn.
We have brought a book on Cardio-Kidney-Metabolic-Medicine, Dr. Chandrashekar. So what is your viewpoint on this? And we are trying to promote the concept of cardiometabolic physicians, because in the Indian context, he cannot have a consultation with hepatologist, consultation
Correct.
with a gastroenterologist, with a nephrologist, with a cardiologist. Virtually impossible. Most of them will not afford.
Right.
So what is your viewpoint on this?
So actually, I should congratulate you on your foresight to have this conference focus on cardiometabolic kidney disease, and now even liver is included in that, right? So it will be CK, LM, right? It's a vital problem. Millions and millions are having that in the United States, in the world, and especially in India. And it's so important that a person well versed in all these facets treat these patients, and you are pushed to start a clinician who can handle all of these in the same place would be an amazing effort. So I congratulate you on your foresight and your efforts to help educate frontline clinicians in this particular field. So, and I look forward to seeing a lot of success.
Thank you very much. Thank you very much for your great takeaways. They will create an everlasting imprint on the minds of the audience.
Again, my congratulations for everything you do for CKM.